In this video, we present the endovascular embolization of a large lumbar type A epidural arteriovenous fistula. The patient is a 64-year-old gentleman who presented with a subacute onset and history of progressive lower extremity radiculopathy, numbness, weakness, and loss of sphincters. He had also sexual dysfunction. Past medical history was only relevant for hypertension and previous lumbar microdiscectomy. On examination, the patient was not able to walk, significantly decreased motor strain and sensation of both lower extremities. MRI demonstrated that he had several vessels in the subarachnoid space and in the epidural space, suspicious for a arteriovenous malformation or arteriovenous fistula. We then perform a complete spinal angiogram, and the only abnormal connection was at the level of the right L4 radicular artery, and you can observe very prominent artery with a one single channel draining into the epidural large vein that ascends up to mid-thoracic levels. Under conscious sedation, we obtain arterial access. First, we try to get access into the fistula from the right femoral, but because the angle of the vessel, we did a better job coming from the left femoral artery. So using a Cobra catheter and a microcatheter, we tried to get access directly into the fistula with a microwire, as you can observe now. But we were not successful. Every time we advanced the microcatheter, the microwire will come out of the fistula portion. We tried different wire sizes and also different shapes of the tip of the wire, but we were not successful. So we decide to maintain the tip of the microcatheter in the most distal portion of the arterial part of the fistula. We first proceed with coiling the end of the lumbar artery. By putting multiple coils, we create a cast, and this is after several coils. This is the very last coils. Before we inject onyx, we wanted to have a cast for the onyx to stay. Here is the final coil cast, and we were really careful on maintaining the tip of the microcatheter really distal on the arterial portion of the fistula. Then we proceed injecting onyx 18. Here you can see, for purpose of the video, we fast forward it, but it's a very slow onyx injection, and we are letting the onyx finding its way through the fistulous portion, as you can see right now, into the proximal portion of the venous side of the fistula. We then wait another 30 seconds before we proceed with a second injection of onyx material. Here you can see on the left side of the coil mass where the onyx is going. Technically speaking, this is probably a relatively easy endovascular procedure. Probably the hardest part of the case was to find the exact abnormal connection between artery and vein. Final angiogram demonstrates complete obliteration of the fistulous portion. You can see the lumbar artery abnormally enlarged, but there is no more early draining vein, and this fistula has been cured. A MRI of the thoracic and lumbar spine. After 2 months of the endovascular procedure, you can observe complete resolution of the spinal cord edema, and there is no more intradural vessels, and the large abnormal vein is no longer there. Most importantly, the patient recovered all his function. He was able to ambulate, and all the sphincter and sexual dysfunction had completely resolved. Thank you.